All right, good morning, everyone. Welcome to Cardio-ECHO, Tackling Type 2 Diabetes. I'm Jessie Lewis, the clinic coordinator. I'll go through the usual reminders. So I think we'll go ahead and get started. I'm going to turn it over to our facilitator, Dr. Duncan.
Well, good morning, everyone. I'm Kathleen Duncan, endocrinologist at OSU, and I would like to first introduce our hub team today. Gautam Rao is our lead. Dr. Rao, are you on the call?
I am. Good morning, Kathleen. Good morning, everyone. I'm Gautam Rao. I'm the chair of Family Medicine and Community Health at Case Western and also the director of Cardio's ECHO program.
Hello, so my name is Trygve Dolber. I'm a psychiatrist and internist at university hospitals involved in population health and really focused on behavioral health integration throughout the system.
Hi there, I'm Dr. Keller. I'm a faculty member at the Wright State Family Medicine Residency, and we work out of an FQHC here in Dayton.
And welcome. So as before, our structure is our brief intro, and that's followed by about a 25-minute or so didactic presentation with questions, and then our 25 minutes for the case study with discussion. We ask that you can please turn on your cameras for both of those discussions, and feel free to unmute your microphone to share in those discussions. Or if not, you can also use the chat feature, and that'll be followed by a brief wrap up. And these are our disclosures, which have been communicated to you in the email from Jessie. And with that, we'll get started on our didactic, which is special populations, patients with chronic mental illness. Go ahead, Dr. Dolber.
All right, thank you. So I'm going to talk to you about this special population. And in order to do that, first I need to, first we'll talk about the objectives. So we'll talk about diabetes in CMI. We'll talk about the different treatments that are specific for people with CMI for their mental illness, and as well as how that relates to diabetes. And then talk about some ways that we can improve diabetes control strategies once we have that background. So we'll start off with what is CMI, because I had to figure that out myself. Chronic mental illness can mean lots of things, but we're going to use it to mean something a little bit more specific here. Many mental illnesses are chronic. I think of anxiety disorders. Many of those can be chronic, even if they're treated. The condition persists, and the patient has to manage it and use their medications and their treatment strategies that they've learned through therapy. I put an example of borderline personality disorder. Even when treated, this remains chronic. I put anorexia on there, which is pretty severe, but not really relevant to this conversation. Some of those disorders are chronic, but they're not what we're really focusing on. In this case, when we talk about CMI, people often use this interchangeably with SMI, which is serious mental illness. And when people talk about SMI in epidemiology, it needs to meet two criteria: persistently debilitating psychiatric symptoms, which severely impair people's function. And those are clearly there's not a hard cutoff for what those definitions mean. Mostly when we talk about this, and especially in terms of diabetes, we're talking about schizophrenia because there's so much overlap. And that's what we'll focus on mostly today, but we'll talk about others as well. Bipolar disorder is considered a chronic and severe mental illness, as well as treatment-resistant recurrent depression. And I put a lot of specifiers there in front of depression. And I'll just use this moment to jump up on my soapbox about depression and PHQ-9 screenings. PHQ-9 and screening for depression is an outstanding screening tool, but it's very non-specific. Once you realize that someone meets criteria for depression, there could be so many things underlying that. Very often there's an anxiety disorder that underlies that, and there are many different types of anxiety. Sometimes it's depression due to just being overwhelmed by medical conditions or social factors. And then actually more rarely, it's a kind of organic pathophysiologic depression that seems to arise spontaneously. And that's the kind of severe treatment resistant depression that we'll see in inpatient units and use ECT for and other kind of treatment-resistant modalities. That falls into the category of severe mental illness as well. And we'll hear more about different types of depression as we go on with my portion. CMI is quite prevalent. When you include all those things, it gets up to 5% of the population. There is some variation by age and sex and ethnicity, but clinically, it's not that meaningful. It's going to be around 5%, so you just need to be on high alert for these things. And why is it important to us in terms of diabetes and cardiovascular health? There is a high medical comorbidity. So CMIs, such as the ones I've mentioned, you can imagine how they can complicate health outcomes just in a very practical way. If someone's depressed or psychotic or having a manic episode, they're not going to be, they're going to be really impaired in taking care of their health. There are often additional mental health comorbidities as well that complicate things. PTSD is common in this population, as well as substance abuse, and those can affect health outcomes. We know that chronic mental illness really inflates the cost of medical comorbidities specifically. I know even at UH, we determine that if someone has a chronic medical condition that's comorbid with a behavioral health condition, they actually end up costing the system 2 to 3 times more. And that's from medical expenses, not from behavioral visits to acute care and providers in other ways. And the lifespan is reduced significantly. So if you have a chronic severe mental illness, you live 10 to 30 years less than your counterparts who don't have a mental illness. Highly increased mortality, and that is primarily from the diseases that concern us here in primary care and cardio, which is diabetes, cardiovascular disease, and stroke. Here is a table that just gives you a sense of some of the common factors, medical factors that are increased in chronic severe mental illness. Diabetes here is one of the ones that's going to be important to us. This is a conglomeration of a dozen or so studies over time. And these studies do have a variety of outcomes in terms of what the increased risk is. So for these, we see in schizophrenia and bipolar disorder, you have about double the relative risk rate of having diabetes. But we'll see that that can vary in some other studies. I've seen it up to being as much as 4 or 5 times increased. And you can see higher rates of obesity, smoking, hypertension, dyslipidemia. All these things run together, as you know. So looking specifically at diabetes, I mentioned we'd talk about depression, and that depression can come from lots of different places. But if you have depression of any type, your risk of diabetes is higher, up to even more than 2 times higher than if you didn't have depression. And like I said, depression as a screener can be a marker for so many different types of mental illnesses and situations. In CMI, we see it up to 4 to 5 times higher, as I mentioned. The age of onset of diabetes is much earlier. So even 10 to 20 years earlier in CMI. Why does this happen? Well, many reasons. There are, well-established diabetes risk factors that we all know about that we consider for all of our patients, and those are increased in CMI. There are disease-specific risks, so specific to whether it's schizophrenia or depression. We'll talk mostly about schizophrenia risks that increase diabetes. And treatment. So we'll obviously talk about antipsychotics and a little bit about antidepressants as well that can increase diabetes risk. And the way you determine these, interestingly, could be different from the general population. And what do I mean by that? Well, before I talk about that, let's talk about schizophrenia and the schizophrenia-specific diabetes risks. There's actually a really heavy overlap in many ways between schizophrenia and diabetes on a biological level. So there is a higher genetic susceptibility for diabetes and schizophrenia, You see this in family studies, you see this in glucose metabolism, and there's even been a common mechanism proposed for the cognitive deficit aspect of schizophrenia and glucose metabolism. I won't get into that in any more detail here. There are, common neuroendocrine pathway dysregulations that we see in schizophrenia and diabetes, as well as nutritional deficiencies. The antipsychotic medications, we'll talk about that more here in a second, but they do have an effect on hypothalamic and dopaminergic regulation. And finally, environmental factors, getting outside the biology to how this affects people's lives. If you have, a mental illness that's either poorly controlled or even when people are doing their best to control it, sometimes that is not sufficient for patients to get a good diet, to get access to good foods, to get good physical activity, to get good social contact, etc. So what have we been doing to try and assess medical risk in chronic mental illnesses? And this actually might surprise you. So if you look at measures like the Framingham risk score, we're seeing that those might really not optimally assess risk in chronic mental illness the same way it does for everyone else. One study found that the Framingham wasn't associated with any changes in intervention models in CMI. And the reason for this is because in the Framingham Heart Study, their sample excluded people with CMI. So it makes perfect sense that the Framingham might not be the most reliable tool in this population. I'm not suggesting that you don't use it, but that you weigh it with other factors. So we don't really have a great equivalent Framingham kind of risk calculator, Framingham-based like ASCVD calculator specific to CMI. So you just need to consider other variables that have been shown to be related. Social deprivation is a big one. Other elements of their psychiatric diagnosis, what kind of medications they're using, and alcohol use have all been found to be contributors. We'll talk more about why those could be the case. But the bottom line is that the standard interventions and the standard risks might not account for important variables in this population. Focusing on antipsychotics. So about 12% of people who take antipsychotics have diabetes. If you look at meta-analyses, you'll see that the prevalence is not appreciably increased in first episode patients. So these, you remember, first episode for men is between age 15 to 25, for women a little bit later, but still when people are quite young. But we know that at the very early onset, diabetes isn't significantly increased. So there's a kind of window of opportunity there for prevention. Many studies, not all of them, suggest that second generation antipsychotics, which are the ones we mostly use these days, because they don't have as many long-term movement disorder related side effects like tardive dyskinesia, have greater diabetogenic potential, and that's fairly accepted. You can see rapidly after starting a treatment with an antipsychotic that things start to get worse from a metabolic standpoint. And we can see that independent of adiposity, so even if someone isn't obese or their lipids aren't changing in the way that you might expect with to be going alongside diabetes, they can be developing metabolic abnormalities through insulin resistance. So it might be a little bit of a different picture than you're commonly used to, and you need to be more vigilant about monitoring markers of insulin resistance. When children are exposed to antipsychotics, they do have a threefold increased risk of diabetes. Now this table or this graph, I want to show you, and then I want to explain to you why it might be misleading. So first over here on the far left, we have schizophrenia versus the general population. This is before any antipsychotic is on board. And you can see in this study, the hazard ratio, and this was a this is actually, I should step back and tell you, this was a study of the entire population of Denmark, an epidemiologic study just a few years ago. So it reflects current treatment practices. Compared to the general population, people with schizophrenia had 3 times the risk of having diabetes. And then separately from that, moving over to the light green bars here, they look at the risk of having diabetes being on various different antipsychotics. Being on an antipsychotic, and again, this is separate from the dark green graph, so don't be misled by that. If someone has schizophrenia and you add an antipsychotic, then their hazard ratio, the hazard ratio of having diabetes increases 3 times. And then you might be surprised by some of these other medications here. So for example, olanzapine having a lower hazard ratio than aripiprazole. Well, that doesn't make sense, right? We all know olanzapine is more related with metabolic impairment. And aripiprazole is one of our go-to medications to try and prevent that. So why is this happening? Well, remember, this is 2017. This is an epidemiologic study and it reflects current practices. So probably the people who are getting aripiprazole are people who their providers already consider them high risk, and people who get olanzapine are probably considered low risk. So this is just to remind you that although we know that the medications are they have their own particular associations with diabetes and metabolic syndrome, even when we use that to adapt our practices, we still see that people who are on, for example, aripiprazole have a higher risk of having diabetes than those who are untreated with schizophrenia. So let's talk more specifically about adverse effects. So I'm going to focus here on obesity and diabetes. Whoops, let's go back and actually look at this. And focusing on antipsychotics, which we just mentioned, you don't see much of an increase in obesity with Haldol, which is an older first generation, lurasidone, which is commonly used more as a mood stabilizer and for bipolar depression, ziprasidone, and aripiprazole, so Giordano Abilify. The high risk ones of inducing obesity as well as diabetes are clozapine, which is actually, we know to be the most effective antipsychotic and the only one that is proven to reduce suicidality. Which is sad because it's so much more effective and stronger than the others and has all the worst adverse effects. Isn't that always the case? Olanzapine, which is probably the second strongest one, and some of the first generation antipsychotics as well. And same thing really with diabetes. We don't see much difference in the risk there. Antidepressants, I'll mention briefly, bupropion. We know that's actually associated with some level of weight loss for most people. Mirtazapine, you always want to be wary of weight gain with mirtazapine. That can happen pretty quickly. Although it is a very effective medication, it does stimulate appetite. Paxil is one of the ones that's one of our FDA approved PTSD medications, is associated with some weight gain. And then the TCAs, which we might be using these also for neuropathic pain and other types of pain disorders. But keep in mind, they are associated with weight gain. Not as much or not as well known that those cause diabetes, those medications. And then with the mood stabilizers, the main one that I want to, the main ones that I want you to be aware of are Depakote and lithium. People with bipolar disorder will spend decades on these medications, and you can see that they have pretty significant weight gain. As a psychiatrist, one of the things that I do is reevaluate old bipolar disorder diagnoses that may have been overdiagnosed back in the 90s. And if I see someone on one of these medications and I think they might not need to be on it, I try and wean it off. That's a conversation that could be worth having with a psychiatrist of your patient if you're running into someone who's having significant problems with obesity or diabetes associated with Depakote. If you have a patient on Depakote who's been on it for a long time, just checking with the psychiatrist could there be another option for this patient? Things are getting out of control. And if there's anything we can do to control them or ameliorate that, they can hopefully assist you. Oops. So what should we do about this? So one approach is minimizing the metabolic liability from these medications. So one thing that can be counterintuitive is you have a young patient, we see this in psychiatry, a young patient who's in good shape and they're 18 years old and they had their first break. And you're like, oh, this is a young, healthy person, we can give them olanzapine. Those people are particularly vulnerable to weight gain. So we try really to avoid the weight gain and metabolic liability related medications in that population. We use second generation antipsychotics with a high metabolic liability conservatively. We try to avoid them whenever possible and really limiting off-label use. And this is something that used to irritate me, people prescribing quetiapine for sleep. And I used to always get mad and say, stop prescribing quetiapine for sleep. It has all these problems and side effects. And really, it's true, at low doses, quetiapine is thought to act for insomnia by helping with, it's mostly antihistaminergic. So you can achieve the same effects with Atarax or Vistaril. But I looked into it, and actually at low doses, quetiapine doesn't have much association with metabolic liability. So from this standpoint, it's a little bit safer. Make sure you screen and monitor per the American Diabetes Association guidelines. I'll run through those. Patients who have a lot of weight gain should try and be switched. These are all things that the psychiatrist should be doing, but you can nudge them because they may not be monitoring as closely as the guidelines recommend. Metformin, we can add metformin and it might be helpful, and I would not discourage it. But if there's a problem with metformin for some reason, you run into obstacles with it, you don't need to push the issue too hard because the benefits are considered to be pretty modest with that. Lifestyle interventions are really the key and medication changes. What are the recommendations for medication monitoring? Well, we get all these variables at baseline: weight, waist circumference, blood pressure, some measure of glucose metabolism and cholesterol baseline. And then we're rechecking at week 12 and then annually. I will tell you from my anecdotal experience, this is, if you find a psychiatry clinic that does this metabolic monitoring, I'd like to hear about it. The onus is really, and I think this is not the way things should be, and we should be trying to change this, but the onus for this monitoring will in many cases fall on the primary care clinic. And that's something you should coordinate with the patient psychiatrist if possible. Make sure these things are being checked and make sure you're reporting that back to them. I guarantee you waist circumference measurements, as easy as they are rarely done. And being aware of developing metabolic syndrome could be something you report back to the psychiatrist. Briefly, I'll give a background for the next thing I'm about to tell you, which is this idea of chronic disease comorbidity. So this is a kind of like a way of theorizing and thinking about chronic diseases that occur together. They can be concordant. So a concordant comorbidity, this has like a similar root cause, a similar pathogenesis, or a similar management where the same treatment will target both. An example that we just spoke about, schizophrenia and diabetes, they do have similar pathogenesis. And some of the ways that we'll manage them will be targeting both with lifestyle interventions that can help both diabetes and schizophrenia by making medication changes, et cetera. Those are considered concordant. What we want to be aware of is discordant comorbidities as well. So these are comorbidities that seem to be completely separate from each other, at least pathophysiologically and treatment-wise, but they do maybe tend to run together. And by treating one, even though you're just treating the one, you could affect the other. So for example, oh, that's just what I just told you. So you can either, if they're concordant, it's important to be thinking about that because you can target both with one treatment. If you think these things are really discordant, then you should stop and think maybe even in more depth and say, well, if I target one, could that affect the other? And I'll talk about that specifically for diabetes and chronic mental illness. There are common factors. So over a third of people with diabetes who are young engage in binge drinking. And we know that diabetes self-care behaviors are really strongly inversely correlated with alcohol consumption, even starting at 1 drink a day. Looking at depression, and these are things that can be comorbid with schizophrenia as well. So looking at depression, that predisposes to weight gain. It's a risk factor for metabolic dysregulation. If you treat depression or the underlying anxiety or whatever the cause is optimally, that will improve glucose metabolism directly and make it easier for patients to manage their insulin or their lifestyle changes or whatever else is going on. They can improve their metabolic state. So let's leverage that and move on to antidepressant drugs. Antidepressants are actually associated with new onset diabetes, up to 1.5 odds ratio. However, we only really have observational studies on this, so it's hard to really draw causation from that. With TCAs and SSRIs is where we tend to see it more, the increased risk. And it does vary between SSRIs. I'm pretty sure it's quite true for all TCAs. So when you're treating a patient for depression or anxiety, the two that we talked about, paroxetine and mirtazapine, can be associated with weight gain. Bupropion can cause some modest weight loss. Most of the other antidepressants are weight neutral on a population level, but this could vary from patient to patient. So if you start someone on a SSRI and they're gaining weight, it's not something you should necessarily brush off, because we do see that on an individual basis. So the key thing to keep in mind here, this shouldn't necessarily prevent you from giving someone an antidepressant, but it should make you think about which one might be best and whether or not you should switch if someone has weight gain. You probably should, if there's no other reason that you can think of that the patient would be gaining weight. And you would really want to think about long-term use. So, you know, in psychiatry, it's easy. Every time I see a patient, I think about what your medication dose is, whether or not it needs to be increased or decreased. If you've been on it for a while, can we kind of step off that medication, start to taper, see how things go? It's harder to do that in a primary care clinic when you have so many other things going on. So do think about that. If you have someone who's been on, you know, fluoxetine 20 milligrams for a couple years, and this isn't something that's coming up in your conversations anymore, make a note to take another look at that. Maybe consider a taper if everything's going well. Sometimes people don't tolerate a taper and they just need to stay on the medication, but sometimes they don't need it and it's worth looking at. Okay, now moving on into some new ideas. So we talked about medication adjustments and how to think about medications. Let's look at everything else. So there have been studies looking into, and this is beyond just chronic mental illness, this thing called chronic disease self-management, which is a set of practices that can improve the health of people with multiple morbidities. And it involves including nutrition and exercise counseling, behavioral modeling, and increased disease awareness, helping people understand how to be aware of physical changes that could be related to the comorbidities they have, how to recognize what's what, and take action accordingly. This does show a modest positive impact on markers of diabetes and cardiovascular risks. And people with CMI have been shown, they're actually acceptable and they're able to implement some of these approaches. So this is something that we could look more at on a population level trying to implement. And as we get more into behavioral health integration, something that we might start trying to work, especially through collaborative care practices that are starting to grow at this point. This is going to be an impossible slide for you to read. What I do want to point out, this is a meta-analysis of different types of interventions for improving metabolic control in patients with CMI. And one thing that I found surprising is that if you look at A1C, you don't necessarily see a change, but the studies that looked at fasting blood glucose did. So this first slide is just the behavioral interventions. Fasting blood sugars improved, A1C wasn't as good of a marker of that. I know my practice in primary care traditionally was always to check A1C, but the more I read lately, the more I'm thinking about transitioning that to incorporating at least using fasting glucose as one of my guiding markers as well. And then looking at other types of drug interventions. So just switching antipsychotics was one, adding metformin or adding another diabetes medication, or adding a weight loss medication in some of these other studies. And you can see similar, there's not much effect on A1C, but there is a little bit of effect to show that these strategies improve markers by looking at fasting blood glucose. So maybe something, I'm not honestly completely sure how I would interpret this. The way I interpret it is, in my practice in patients in this population, I want to be looking at fasting blood glucose and not just A1C as a marker of improvement, but I probably want to be considering both and just having an awareness that I may be affecting one and not the other. Okay. So how do we practically, putting it all together, how do we support adults who have comorbid diabetes and chronic mental illness, or who may be at risk for developing diabetes? The diabetes education is crucial, and it needs to incorporate the cognitive deficits that some patients with schizophrenia could have, or mood states such as depression, severe depression that could cause people to have impaired concentration, impaired ability to remember what's being told to them about their controlling their disease. You might need to be repeating education. You might need to be doing teach back. Really, I mean, and we do this for all patients, but really increasing your vigilance in this population on education. Thinking about which psychotropics are going to minimize metabolic factors and weight gain. Optimizing the outcomes of comorbidities. So we talked specifically about substance use disorders and depression. Those are highly comorbid with chronic mental illnesses, and focusing on optimizing those can improve control both of the chronic mental illness and metabolic factors. Addressing all the biobehavioral factors that we talked about with self-management support. And possibly a way to leverage that and everything else is through the collaborative and integrated care models that we're developing now and integrating more and more in Ohio. That is it for my section. So if there are any questions right now, I can answer those.
I think we can take a couple of questions. Thank you, Dr. Dolber. That was great.
Thank you, Trygve. That was a great overview. I really appreciated that. The issue of atypical antipsychotics and weight gain and metabolic disorders is a very serious one, as you know. It's something I dealt with for about 20 years because I used to treat mostly children and adolescents with weight issues. And as you're probably familiar with Joseph Biederman from Harvard, who published an article about advocating the use of these drugs, the problem got so serious that we kind of gave up from the endocrine primary care perspective, trying to address the issue. We worked directly with psychiatrists, and Ben Goldstein developed a protocol whereby these kids would be put on metformin, maximizing the dose to 2,000 milligrams a day, as long as they were 10 or 11 years old and had normal renal function, and giving the parent or the child themselves a brochure saying that you will almost certainly gain weight on these medications, even though it's going to improve your child's behavior. The teachers are happy, the parents are happy, the doctor is happy, the psychiatrist is happy. So that's what it really took, and that sort of advising the patient themselves that this is something that is going to be difficult. The other advice we gave to families was that the way it promotes weight gain is through really hedonistic mechanisms, reward centers in the brain. So if they liked chocolate before they went on these medications, they're going to really like chocolate afterwards. And having the parent being aware of that was helpful. So I appreciate your comments about it. It's a hugely challenging issue. The other question I had for you deals with diabetes self-care and what your experience has been. And are patients with chronic mental illness of a certain severity, let's say it is someone with schizophrenia, are they able to do things like self-monitoring of glucose, or what's been your experience with that?
Yeah, good question. I would say it varies based on severity. And there have absolutely been times when I've been stymied by very often patients with schizophrenia that is kind of, we're doing our best and it's just good enough, right? Sometimes our best is just barely good enough to keep people stable. And a lot of these patients end up living in group homes, and they have someone who's running the group home who doesn't really help them with their medications, and they have to manage everything on their own. And people can do it, but I think it really requires frequent contact and assessment of how people are doing. If someone's struggling, you know, as with any other patient, if someone's really struggling to get their numbers under control, really consider cognitive factors as a component. Try some teach back, see if people are doing things correctly, if they understand things correctly. If they do, see, could there be you know, illness-related barriers that prevent them from doing these things? Illness or social, due to the illness-related barriers, you know, in their group home, are they able to get access to their insulin? Are they able to get access to their test strips, everything else? Is this incorporated into the meals that they may be having together with people? And then, you know, I would say if either of those things are failing, it might be a, and I've never tried this, but it's an idea, looking into having some kind of home health aide who comes and assists at least from time to time with blood sugar management, traveling out to the home and making checks. And incidentally, if people are familiar with ACT teams, this is the assertive community treatment teams for people who, generally for people with severe mental illness who are pretty unstable and are getting admitted to either the emergency room or getting picked up by police and going to jail, might be eligible for an ACT team. And ACT teams will go out to the patient's residence on a very frequent basis to try and help keep them stable. And some ACT teams these days are trying to incorporate some of these medical factors as well, including a nurse who can check on the patient's glucose control. So those are all things, there may be things that, there may be ways that we can assist for this in patients who have trouble monitoring things on their own. And we might have to get creative about it and use our case management and see what's available. I think there are multiple options that I'm aware of. There may be more coming through the gateway. There may be more that I'm not aware of. Sometimes it might involve getting family members or social supports involved, educating them, having them help. I guess that's a very long answer to your question. Yes, I think some people can do it themselves, but you need to be more vigilant about what if they're not able to do it themselves, or they're having a hard time, and how can we assist with that and be creative.
Thanks, Trygve. That's helpful. So I think that the bottom line is it's worth trying, at least, not to give up on them.
Oh, definitely, yeah.
And I really think your point about chronic disease self-management is really important, and it mirrors a lot of the concepts that are inherent to diabetes self-management. Although I was not familiar with any sort of a referral process or how, you know, that might roll out. Would it be only through, I mean, I'm assuming it would not be just through, you know, a psychology referral or behavioral health referral. How are people doing that?
How are people referring for which, for
chronic
like
disease self-management?
Oh yeah, so I think that's going to be practice dependent. I don't think there's a really nice universal formal way that that's done. Even at university hospitals, it varies from clinic to clinic, and what resources are available there. That's something that I think we need to be working towards. I don't think it's something that we necessarily have referrals available for right now. It's something where if your clinic has diabetes educators already, it's something that you would want them to incorporate. if you're thinking about expanding or broadening your diabetes education plan, and you've got some population health data, you could look and see the role or the prevalence of chronic mental illness in your diabetic patient population, and then consider implementing some of those measures more formally. But as far as, is there a standard universal referral process right now? I wish there was. I'm not aware of one. Maybe other people are, but I'm not.
Okay. All right, well, in the interest of time, why don't we move on to the case? I'll jump off here first. So the question of whether she's type 1 or type 2, I'm sure most certainly she is type 2, but it probably is worth going through, you know, all the checklists with her and say, you know, here are the reasons why, you know, do you have a family history? What's your body mass index? You know, her BMI is pretty high, and how long she had diabetes. It might be possible that somebody told her, well, we're treating you more like type 1 diabetes because clearly something has failed, and maybe that just sort of stuck with her.
Yeah, that's kind of what my guess is, knowing the doctor that had her before, is that he said probably something like that, or said, oh, well, maybe you're a type 1 diabetic and that's why this sulfonylurea and the metformin have failed, because it was probably back when, it may even have been back far enough that all they had was sulfonylureas.
And it's possible she's had it a long time, that maybe her C-peptide, you know, has started to decrease. Who knows? But it seems unlikely if her A1C was 7.5 with just an oral agent.
Yeah.
And then the other possibility with the insulin is I've had this happen a lot of times, where people who are on multiple injections of insulin a day, they feel like they have some control over their blood sugars and they can adjust their insulin. They've gotten good at that. That might be something that you might even be able to harness with her, and even, you know, see if she would, you know, like to use a continuous glucose monitor so that she could see her own readings more readily. And it's not to say that you can't add in other agents, just kind of couch it in that those other agents help insulin work better.
Kathleen, I'm just curious, would you just to settle the issue, get some islet cell antibody levels, assuming she hasn't had them before?
She hasn't had.
She probably has.
Yeah, she hasn't had any testing that I can see. You know, maybe way back something was done, but we only have about 4 or 5 years of records.
Yeah, because even if her C-peptide's normal, there are all sorts of kind of gray overlap areas that, you know, I've had people with multiple antibodies, you know, need very little insulin for years when they're diagnosed as adults. You know, when they're diagnosed younger, it's very classic progression.
I have a couple questions. One, can you remind me, because I didn't catch it at the beginning, you mentioned something about overdose of the kids when she got home. Do we know like what that was that they overdosed on?
There was alcohol and another, what I remember is alcohol and another street drug. I think it was heroin. I'm not sure.
Okay. And then so the last time you saw her, that was when she mentioned that she thought she had type 1 diabetes. So you haven't had a chance to explore that yet. I think the simplest thing, and I'm sure this is what you're planning on doing next time anyway, is asking where she got that idea from. I did ask her, and she said, well, my doctor told me that years ago. And she doesn't remember that it wasn't at her first diagnosis. She just remembers that it was a long time ago, about the time she was diagnosed. I couldn't tease out in the time that we had and I don't think she even remembers if it was very, very, you know, early enough that she could tell if it was her first few visits. She remembers being on some oral agents and that they failed. I was going to try and make some kind of exciting Freudian comment about how if her kids had overdosed on something oral, then maybe she would have some kind of avoidance to that. But it sounds like that's probably not what it is. But one thing I will say, though, is, you know, with her, it sounds like, and obviously I don't know very much about her, but it sounds like maybe her depression is related to PTSD. If she does have PTSD from that encounter, which is very possible.
I think so.
And when it comes to treating PTSD and titrating antidepressants, and people who have depression that arises from other conditions, what I find with my patients is if I target my treatment on the depression, sometimes that can be misleading. And sometimes people might say like, oh, I'm not feeling depressed, I'm doing great. And really what they mean is their mood is good, but they're still having to change their life and their mind in all kinds of ways to adapt to this disorder that they have, but it just become normal to them and they just think that that's how they have to live.
Yeah.
And so you think that the antidepressant is at the right dose and it's working and everything else because their mood is good, but actually their PTSD symptoms may not have been touched yet by the medication. It might not be the best med, it might not be at the right dose, whatever. I don't know if that's what the case is with her. Sounds like you tried lots of different things, but I always, and I haven't always done this, but lately I've been more thoughtful about trying to think of if someone has depression, what's the underlying cause of that? Because very common, it's some type of anxiety disorder. Assess for that, and then when I'm treating them, assess the symptoms of the anxiety and see if those are improving as well as the depressive symptoms. Because the depression can come and go based on other circumstances, but the anxiety is really the root problem. So with the PTSD, medication obviously can be targeted towards PTSD, but and then counseling, quite frequently, we have people do counseling for PTSD, and counseling is helpful, but I find counseling to be helpful for people to live with the disorder and manage it. And I see someone mentioning CPT who's reading my mind. And especially if this is kind of a complex PTSD, there's probably some guilt tied up in it and some complex grief involved as well. CPT would be a great treatment. So I just want to draw a distinction between the different types of therapy that people can get. There are therapies that involve exposure therapy and cognitive processing. So like CPT, prolonged exposure, and EMDR, which there's some controversy over whether the eye movements have bearing on that, but regardless, when you do EMDR, you're doing exposures. And when you give someone exposure therapy or CPT for PTSD, you're actually reducing their PTSD symptoms, and that can persist for a long time. So if you think someone's got chronic PTSD that's causing them to have exacerbations or like intermittent depression that may come and go, or other problems that may come and go, substance abuse disorders that may come and go, this is interfering with their health, it might add weight to an argument to get them seen by a therapist who can do one of those more kind of, I would go as far almost to say is not necessarily curative, but the evidence-based therapies for PTSD or other anxiety disorders that can actually long-term reduce the symptoms rather than teach people kind of how to adapt to and live with their symptoms. Yeah.
Thank you. I will look into that. We sometimes I have had some difficulty getting a therapist, especially she's on Medicaid, that does the CPT and the EMDR, but I have not worked with that with her, so I will try.
It's the hardest thing to do. There's so many barriers because, like you said, it's hard to get people into weekly therapy. Therapists who do evidence-based work like that might not be available or are hard to find. And then there's the whole patient side, right? Because the reason someone has an anxiety disorder is because they're avoiding this thing that they're horribly afraid of. And now you're going to say, oh, for an hour every week, you're going to go look at this thing that you're trying as your best to avoid, and that can be a really hard and
hard sell.
That's a hard sell, and you have to come back to it over and over again in my experience.
Yeah, I'll work on that.
Well, thank you, Dr. Keller and Dr. Dolber for this wonderful discussion. Unfortunately, the hour has flown by. We are at the top of the hour. So I'm going to turn it over to Jessie for our wrap up.
Great, thank you. Rick, I'm going to skip this for time's sake and go to the next slide. So just to let you know, you should actually have 2 surveys in your inbox this week. The first is our typical post-clinic survey for feedback on this session, which will close tomorrow at 5. And then the second survey is actually 2 open-ended questions for you all to put in comments on things you'd like to hear more about, or perhaps we haven't touched on, that will kind of inform our didactic for our final week next week. And then just a note on CMEs, and I can go through this in more detail next week, but you'll be receiving an email from myevaluations.com probably on April 6th. So you go through some steps to register there, and you'll have till April 23rd to complete a survey if you're interested in claiming CME credit. And then lastly, we just wanted to mention that we do have our dates selected for our upcoming series. So the fall 2021 Cardio-ECHO Clinic will be from September 16th to December 9th. And it'll be in the same time slot. So Thursday mornings from 8 to 9. We just wanted to let you all know, and we'll have some more details and information on registering in the coming weeks. So I know we're a little bit over. We'll see you next week for our final week of the series. Have a great day, everyone.
Bye, everyone.
Thanks,
Bye, everyone.
everybody.